Well, those were 4 fantastic presentations. I want to thank you all for traveling here and helping us with this. And we now have the opportunity for some questions and answers. And I wanted to start with one. The previous panel talked about policies that sort of get put into effect and then implemented through legislation. You all are, the 3 of you who talked about different kinds of policies, are really, in a way, talking about institutional priorities. And it's beyond just what legislation could do, but what particular institutions could do. And as you're thinking about making the case to those institutions, I want to ask a question about the strength of the evidence. So for example, Dr. Buggs, you talked about evidence for community-based violence interventions. And I'm going to ask you in a second to talk about how that evidence compares to the evidence of law enforcement interventions. Dr. Cooper, you talked about projects in the hospital, and I'd like you to think about, and I'll come back to you, what hospitals could do to prevent recidivism compares to other things that hospitals do all the time. And then Dr. Branas, you talked about the value of cleaning up and improving very rundown areas in urban areas. And cities have to make priorities decisions all the time about where to put resources. And I wonder if there's a good point of comparison as you think about talking to city policymakers to invest in these kinds of strategies. How does the evidence, where the other, what kind of evidence are they looking at for the other ways that they might spend money? How does that compare? So we'll start with you.
So we know that there are law enforcement strategies that can work to help reduce gun violence. And the strategies that have been most effective are those that, again, focus very specifically on the issue of gun violence. They are very precise and focused on individuals most at risk for violence and the problematic places, problematic street corners or bars, those kinds of places where violence recurs. But what we found is that the community-based strategies, in terms of investment, cost far less than law enforcement strategies. And importantly, where law enforcement engages with communities that are most impacted by gun violence, those communities often have great distrust of law enforcement, and there's a breakdown in communication and in relationship between the community and the police. And so we know that law enforcement can make a difference in terms of gun violence reduction, but it is really important to engage the community in the kinds of changes that they want to see. As Dr. Branas talked about, going out into the community and asking the community what they want to see can direct us to the actual problems that are helping to create the gun violence, rather than assuming that we know what the problems are.
So for a city that's looking at some very targeted law enforcement strategies as well as community-based anti-violence initiatives, would you say that the impact of those is generally comparable, or would you say that one is clearly better than the other? In other words, should this be part of a city's discussion if they're thinking about gun violence, even as they're discussing law enforcement?
So I'll re-echo the point that's been made, that there is not one policy, there's not one strategy that's going to be most effective. A comprehensive strategy really is what will make the difference. And we did a study in Baltimore of various interventions, including law enforcement strategies, to reduce gun violence. And the one intervention that mirrored reductions in gun violence was by a special enforcement team in Baltimore that was focused specifically on gun violence. Now, the challenge is that we also saw that special enforcement team has been associated with civil rights abuses and discourtesy complaints and actual physical violence. So you have to, weigh the costs and benefits of having law enforcement without checks and balances over those teams, and they need to be focused very specifically on the gun violence activity. And so, again, community-based strategies can work, but it is very important also. I talked about implementation challenges for some of the community-based strategies. You need to engage the community And you need to consider where there's accountability, where there are feedback loops in any of these strategies, so that there can be checks and continually improvements made on the strategies.
And that Baltimore study also evaluated some community-based.
Yes.
And how did those fare?
Yes, so we looked at the Baltimore's version of the cure violence model. And again, it was found to have effects, reductions in gun violence in certain neighborhoods, but some of those effects did attenuate over time. And so we have seen that it can work. The community-based strategies do work and can be equally effective or even more effective than law enforcement strategies. We saw that some of the law enforcement strategies that were employed did not work at all. Some were associated with increases in gun violence rather than decreases. And so, again, it's important to consider a comprehensive strategy and to really engage the community in the process so that they are part of the solution, and we can have the kinds of accountabilities and checks that we need to make sure that any of these strategies are actually effective and making a difference, a positive difference in the communities.
Great, thank you. Dr. Cooper, so how did the evidence for violence interventions in the hospital compare to other kinds of things that hospitals might be investing in? Because, new surgical procedures, new surgical devices, all those different things, how does this compare?
Well, be clear, our nation's trauma centers do an excellent job of caring for our patients who prevent violent injuries. And we save lives every day, and we are constantly investing in new products and new techniques to save those lives. So we do a good job overall. However, we are missing opportunities. Yeah. I can tell you one of the toughest jobs I have, one of the things I do as a trauma surgeon is after spending 4 or 5, whatever number of hours in working on someone and then failing and having to come out and talk to that family. It is the toughest job in it. You walk into the room and it seems like there may be only 3 people there. It seems like 10 or 15 sometimes. You try to identify the most important member of the family and you focus on them. And you can't say your loved one is sort of passed on. You can't say they've gone. You got to say your daughter is dead or your son is dead. And then the scream that comes from that sometimes, it's like it reverberates through you. And all you can do is sit there and hold their hand or put their arm around them till they stop screaming. It is the toughest job that I do. Clearly, there are patients. The data shows, again, when those patients come back with violent injuries, they are more likely to die for whatever reasons. I mean, it's unclear why. Some people say it's because their immune system is depressed. It's more than likely because it's more difficult to operate on someone a second or third time in their belly when they've had multiple operations. It's just more challenging. And so their likelihood of that surgery being unsuccessful is more than likely. But we really don't know why their death rate is higher, but it is higher. And that's why hospital-based sponsored missions are helpful, because because that higher percentage of folks who die when they come back. It's an opportunity to intervene in a way that hospitals, again, have already failed. And I can't emphasize how much what it does for the staff as well. Because if you're a surgeon or a nurse and you're sitting at ED and at trauma and they're constantly coming in, you get a little bit down after the 3rd or 4th person comes in and dies. And having something else you can say that, especially if someone you've seen before. I saw him a year ago. He's died now. What could we have done different? And I think it's very important for the hospital staff to be able to say, he's here, we saved him, we have an opportunity, we have something we can do now that can make sure that person doesn't come back again. So it gives the staff more hope rather than saying, why are we doing this? He's just going to come back in 12 months. Why are we wasting all these resources? I mean, I know it sounds a little callous, and I would like to say that never happens. We're humans. when you're seeing that I mean, when you know those folks, just patients are going to come back again, and you're going to research like mad, those sort of things creep into folks' mind, I think.
I want to encourage people who are watching to join the conversation at the hashtag gun policies that work. But I want to go back to you, Dr. Cooper, for a quick follow-up. So if this weren't gun violence, but you had an intervention that could have a similar impact as your gun violence intervention program on a serious illness, say it was on car crash victims, or, and you could do something to have the same impact that hospitals could have if they implemented these policies. Do you think people would say there's not enough evidence, or do you think if, let's say, there were a machine you could do and bill for, what would be the reaction? How does this compare to other things that hospitals might do?
Well, I think that that if it was something more concrete, I think that hospitals would react in a more of a solid way, going, yeah, that works. We're going to institute that. It's the fact that that you have to have the data is so dependent upon having a interaction with individuals and impacting them in a way that, on social issues. Hospitals aren't really equipped to deal with the social issues that bring these patients to the hospital, and that's why having the hospital-based violence group, which is really a group that's able to not necessarily, well, they're embedded into the hospital now, but often they bring expertise outside the hospital. So I think that being able, part of the issue is being able to show them the data that says that it's not a new anticoagulant, it's not a new tube you can put in, et cetera, but being able to say that we have the data that says addressing the social issues that, such as work, getting folks in jobs, substance abuse, et cetera, that hospitals aren't used to.
Right.
Yeah, doing.
Might be better than the new anticoagulant.
Might be better to do that.
Yeah.
But one of our jobs, we have to continue to provide the data that does that, and more data that does that, so we can convince it's not the trauma surgeon, but it's also convince the chief executive officer and the chief operating officer, all those folks who have the money. Let's invest in that.
As well as the insurers, as you pointed out.
As well as the insurers, right? That's
Great.
Yeah.
Dr. Branas, so question for you. How do these conversations generally go in cities? Is it a little easier sell now that you have randomized data? And what are the competing priorities and what's the evidence for those?
Well, I just want to first say thank you so much, and that gun violence is definitely in your lane of what you are supposed to be doing, not just in the hospital, but in the community. So we're so pleased that the hospitals are investing in this sort of thing, and have been for quite some time, but unfortunately have not been recognized for that kind of community-based work. So cities are always doing trade-offs, and to Dr. Buggs' comment that for most cities, one of the biggest line items in their budget is law enforcement. So most cities are investing a heavy amount of their funds into their law enforcement practices. And by the way, law enforcement works. We know from cities, and some great experiments, in fact, cities like Kansas City, that law enforcement has the capacity to reduce gun violence, and things like focused deterrence, which Dr. Buggs was presenting, are this attempt to blend traditional law enforcement with more community-based programs. And so that's nice, and that helps to bring law enforcement into the community and to build community relationships. That being said, there are two issues. One, which you raised, which is that law enforcement and policing isn't always welcome in many of these communities. When I said that we asked the community members what to do about the violence in their neighborhoods, very few of those people said more police, to be quite honest with you. So that's one thing. It's not that policing doesn't work, but the community relationships with our local law enforcement agencies is challenged. Now, the other thing that I will say, and one of the reasons that we as scientists began to pursue place-based interventions is whether it's policing or interrupters, these person-based strategies where people have to be there, perhaps having a great impact in reducing gun violence, but that impact only lasts while they are there. So if you look at, for instance, if you watch The Interrupters as a documentary about the Cure Violence program in the city of Chicago, it's doing quite well until the money runs out. And the interrupters can no longer be present in those communities, and the violence returns to those communities. So we really were thinking about these place-based strategies in a way to convince the municipalities and the policymakers in municipalities is that perhaps there's a bit more sustainability on these if they're married with other community-based programs that bring police or interrupters or other community-based practitioners into the field.
Great, thank you. Dr. DeGutis, do you see a more of an openness to funding research in this area now that this conversation has gained momentum nationally?
I think that, we hear more about a desire to do some funding, but we're still not seeing any action on it. Okay. I think where we're seeing the action has been on the state level for a few states, and then from the private sector from some foundations like Bloomberg, who actually are funding some of the research, and there's one or two other places that foundations are funding research, but
well, certainly our hope as people watch this and really become familiar with just the evidence that's there, really being compelling and showing the value. Let's go to maybe some of the questions that have come in online.
Yes, we have had a couple of questions, and I'll just provide you with two. First is if any of the panelists could talk a little bit more about gun violence prevention in schools. And then also directly to Dr. Cooper, does your program work with community partners in public health departments?
Well, I'll start. So when we started our program, of course, it was just hospital-based, trying to work with the folks who came there. But then it was obviously, clearly a question is, how can you work with patients before they get to your trauma center or your place? So might go?
Yeah, it's okay.
yeah.
Oh, it's dead. Sorry. I'll talk a little louder. So what we did then was we actually partnered with schools and began to go out and talk to them about things that put them at risk of violence. We actually we partnered with things like the PALS program, Post Athletic League, and had them bring groups to our hospital where we would talk about risk-based behavior, and we would. Thank you. And we've given examples of behavior that resulted in an injury to a patient, and asked him, what would you do? My classic example is there's a kid that came to me in Baltimore, was playing basketball in Baltimore, and he saw some other kids show up. He knew they had a beef the other kids playing basketball with, and he said, well, I knew something's gonna happen, but I'm having fun. I'm playing ball. I'm winning. I stay on, and then of course, what happened was he got shot and came to me. So we gave examples like that, asked him, what should that kid have done differently? So we've gone to schools and tried to do those kinds of things and partnering with schools. And the second question was?
Is your program working with community partners in health departments as well?
Absolutely. I think that we welcome any partner who can help with education, can help with funding, can help with getting access to the communities that can result in our patient lives being saved. A quick example, for the hospital-based programs, this is our 10th year now. All of the processes and intake forms, et cetera, we share. There's no copyright on any of it. We share it with any place that wants to develop a hospital-based program. We will go out we travel to many cities, sometimes on our own dime, to help them be educated and walk through the process of building programs. Again, simply because we feel very strongly, and our growing data shows that it saves lives.
Anyone else want to add to that, Dr. Buck?
On the topic of gun violence in schools, there have been replications of the cure violence model. Some violence interrupters and outreach workers are reaching into the schools and helping to mediate conflicts within the schools, but also providing mentorship and support for the young people who are at greatest risk for violence. But one thing that we also see is that young people frequently, when young people have guns on them in school, they've been arming themselves because of their commute to school. They are passing through. My mic is out too. Thank you. They are passing through dangerous neighborhoods to get to schools, and so it is really important to think about the environment, as Dr. Branas talked about, that young people are having to traverse to get to and from school. In addition to providing them support, the question was raised earlier about ACEs, adverse childhood experiences, for mass shooters. But as was pointed out by the previous panel, that is a common feature. Dr. Cooper mentioned it as well. These individuals who are at greatest risk for violence have had extensive trauma in their backgrounds and really do need support and mentorship and connection to services. And so some programs are reaching into the schools to help identify and support those young people.
Great. Question?
Good morning. Good morning. Thank you today for all of the panelists and all of the great information being shared. My name is Amy Moyer, and I work for Kaiser Permanente. And as many know, we're an integrated health system. And I have two questions. I promise not to be long-winded, but everything you're saying resonates with where I come from. And I work in the department that does a lot of the community investments and grants for community benefit. So it's not only investments for our members in the community, but the communities and where we operate. And one of the areas that we focused on most recently, based on an environmental scan, is West Baltimore and the 21223 zip code. And we created a place-based initiative called Future Baltimore. And it took about a three-year process, but we joined with Bon Secours and some other nonprofit organizations. But to date, we've done 1,200 screenings for behavioral health services. This is all with community feedback is what they wanted. 100 certified nursing assistants graduated from programs that we created. We have 11 micro businesses graduated from an incubator program, and they've already received $100,000 in loans. 75 families per week receive fresh produce, and $6 million in capital was raised for a community resource center, which the community said they wanted. And we provided $2 million. Our initial investment was $2 million. I'm saying all this to say that it took a lot of energy and buy-in from other nonprofits or other private institutions. And so I guess I would say is providing the business case, even the research is there, what would you say would be the top things that organizations like ours and others could do to get involved in something like this as either corporate social responsibility or not as only a means to prevent violence, looking at the root causes, social determinants of health, but how can people get involved with this, knowing, because we operate from the standpoint of social determinants of health. And so that's the first question. The second one is about hospital interventions, but I'll let you answer that first.
Why don't you go ahead and quickly ask the second one?
Okay. So the second one is last year we also contributed $2 million to gun violence research. And when you mentioned the hospital intervention, some of the things that our physicians and clinicians thought were important to do research on was, one, evaluating a web-based education tool for safe firearm storage in patients at risk for suicide, and then understanding risk factors of firearm-related injuries and death in adult and pediatric populations, and then integration of firearm suicide prevention tools in healthcare settings. So that's the patient-reported access to firearms and decision aid for storing the firearms. Would you say those are three areas that could be incorporated with the hospital-based interventions that Dr. Cooper spoke about?
Well, thank you for your question, and I should also say that Kaiser has been a very good supporter of the Health Alliance for Violence Prevention. At our annual meeting, our 10th annual meeting this past September, you were a supporter, and we're very thankful for that. We try very hard to make sure that we educate our clients and any patients come to the hospital with injuries on the kinds of things that we talk about. I mean, we have those with our clients. We have those very tough questions about: are you still carrying a weapon? Is there a weapon inside your home? We try to make sure that we hold our clients accountable. We're investing in them. They're part of our program. So we do have those tough questions with our clients themselves. We've not gotten more broadly in having those questions in the general population of our hospital, but those are things that are, again, at least being discussed as we try to broaden our success efforts.
Great. And thank you. Anyone else interested in responding? And we should use these mics if we're going to do it.
I'm happy to use that. I'm happy to try to answer your first question. So first, wonderful work that's being done in West Baltimore. Congratulations. I love to see it. And it speaks to this notion, and Dr. Cooper will know this, of course, is that healthcare is really not simply about what happens in the walls of the clinic, whether that be the walls of the hospital or the walls of some satellite outpatient clinic. The providers need to understand the context from within which their patients emerge, because if you keep issuing the same treatment to them when they show up at your clinic, they're going to return to a chaotic and a difficult environment that's not going to permit that treatment to work. So that's the first reason that you need to be thinking, well, I'm not saying you necessarily, that the health systems need to be thinking about beyond just the walls of their clinic. Now, the other thing I'll say is that I'm going to applaud you, but say that there's not enough of this going on and emerging from healthcare systems around the nation. The other great example that I have in mind is Nationwide Children's Hospital in Columbus, Ohio, that has just built hundreds of homes, built and rebuilt hundreds of homes in their surrounding area in Columbus. And they're reaping the benefits of that in terms of the cost savings, because folks who've been showing up over and over again to that hospital might not be coming back over and over again for various issues, including acts of violence and violent injury. So there are a lot of benefits here, and I'm so glad to see that your health system and others are really investing in this, not simply offering it lip service, but going into the communities to do actual programs and to perform actions in those communities to try to address this.
And I would just say, I think it raises the question also for businesses where their line of business is relevant to gun violence, and we've seen some businesses stop selling certain types of guns. You know, think about that. For a healthcare business, it's also about opening clinics. You know, and West Baltimore is a real desert when it comes to primary care, and I think there's been an interest in a long time in more primary care in West Baltimore, which could combine with some of the great investments that Kaiser is making on the social determinant side.
Thank you.
Great.
Hi.
Josh.
Josh Horowitz,
Yes.
the Educational Fund to Stop Gun Violence. I want to think about some systemic issues that might link this incredible important discussion about urban gun violence with rural suicide issues. So we're seeing a complete, some of these cities we're hearing about this disinvestment, Dr. Sharfstein brought the lack of mental health services in some of these communities. We're seeing that actually mirrored, I think, in rural America as well, where you see some cities with really, empty storefronts, blighted buildings, blighted parks, no access to services. Do you think some of the strategies that we're talking about here in this panel could be applied, for instance, in rural America to deal with some of the suicide crises we're going on? And maybe Dr. Branas, you can start with that, because I was really taken with your discussion of sort of putting parks in and getting rid of blight. And that's something the more you spend time in rural America now, you're seeing that being mirrored in small towns all across the country. So I just wondering if there's some commonalities we can sort of bring together here.
Yeah, and it's one of the reasons I said that big cities, mid-sized cities, but also small cities, which were disproportionately affected by the Great Recession, frankly. So rural and semi-rural America is very challenged by this, as you're saying. But then I'm going to put my hands up and say that we haven't devoted the research energy that we should, particularly in terms of place-based interventions for the challenges of rural America. Particularly for suicide and gun suicide, that we have, the $300 million that went to the opioid crisis, much of it was focusing on the rural crisis. We haven't even scratched the surface for what's coming up right under that, which is suicide and gun suicide, particularly in rural communities where the risk is even higher than in our cities. The one thing I will say that we've been thinking about is this. I don't know if any of you have followed, but the UK has created a minister of loneliness. So in the UK, they really are addressing loneliness as a health concern, a major health concern that's driving a number of different things. And I think there are opportunities to begin to think about that and perhaps some strategies that have emerged from folks who are thinking about addressing these issues of loneliness, particularly isolation that occurs in rural areas, and applying them here and seeing if they have some kind of an effect on particularly rural and semi-rural gun suicide.
Thank you.
Great. Next question.
Hi, good morning. Thank you so much for all of the information that all of you have been sharing, both on this panel and the previous one. My name is Ruhi Bengali. I'm going to keep my question short. I was just wondering if any of you could speak a little bit about policies and practices that address police violence specifically, so much of which is gun violence, and that doesn't quite get the attention within the gun violence space as it should, and really undercuts, at least in my view, so many of these programs that you shared about, because it really is sort of what is driving the mistrust of police in those communities.
Yeah. There has not been enough research on police violence. That is, you're absolutely right. It is a critical piece of the puzzle. When you talk to community members about what they need, and the communities most impacted by gun violence, about what they need to feel safe, as Dr. Branas said, there's not a call for more police. Often there is a call for no police because of the history, because of the many stories of concerns about police violence. And police-involved shootings receive, similar to mass shootings, they receive the most public attention. But there are also concerns about harassment and humiliation and disparagement. And so there needs to be more research on that. And I believe that the strategies, it's quite possible that many of the strategies that have been discussed could also help address police violence. And there needs to be real, honest conversations around how the police engage with communities. And is it the kind of engagement that the communities want? And too often, communities are not part of the conversation. It is a top-down assumption about how communities should be policed, and it is not working. We continue to see high rates of gun violence in communities where there are high police presences. And so the strategies that have been used are not working. The investments in public safety, focusing only on law enforcement, is not gaining the lives that we want to save. And so you're absolutely right, but there needs to be a lot more research on police violence and its relationship to violence in the communities.
Thank you. Maybe we're close to the last couple questions here. Go ahead.
We're both fielding some from our live stream audience. Dr. Branas, some people would like to know, you talked a little bit about anti-blight ordinances, and you said there are good ones and there are impotent ones. Good ones and impotent ones, and they wanted to know, did you have kind of maybe a short list of what a good anti-blight ordinance contained?
I think, so there are good ones, impotent ones, and completely absent ones. So we have to start somewhere and put some in place, and ones that don't function as well don't give the city the capacity to make changes. It mires the opportunity, even after perhaps an owner of a blighted property cannot be identified, or has passed away, or has not been an owner of that property for decades. Many cities, in the absence of an ordinance, or an ordinance that doesn't function strongly enough, it will take the city much too much time to be able to act. As researchers, when we do our research and go into communities and change these properties the community doesn't think we're coming from a university. They think that we're coming from city government oftentimes. And the common response is, we called you 30 years ago. No joke. We called you 20 or 30 years ago to do this, and we gave up after a while. So I think that some communities do have these mechanisms, some cities do have these mechanisms, but they're just mired in red tape, and they're not streamlined enough to be able to get in there and make the change on behalf of the neighbors.
Great.
So we have another question from Twitter, and it's about funding. And the question was, even when funding has been allocated, it's often not released appropriately, or it doesn't go to the programs that truly support the policy. How do we overcome those hurdles?
No, that's a good question. I think there's a number of things. I think it depends on where the funding is going to, so where the money is appropriated to as far as funding goes. When you talk from a federal level of funding, there are, some agencies are more likely to maybe follow their own priority research agenda than maybe a more general research agenda, so it really depends on that. I think it depends on where the research is going to get done, and what they've made decisions about as far as where that money is going for the research. Are they keeping it internally, or are they giving it to independent researchers? And I think those are some critical issues, because you do have places where the research is done in-house, and when you talk about things that are governmental and it's done in-house, there's more politicization of that kind of research than there would be in an academic environment, or in research that is funded perhaps by a private entity, or by a foundation. So a lot of it has to do with how the money is appropriated to the distributor of the funds, I guess is the best way to say it.
Thank you. Please join me in thanking this great panel.